In this week's podcast, we're going to be talking about probably the hottest topic in health and medicine today, and that is Ozempic and the GLP-1 agonists, basically the prescription medications that are being used by millions of people for weight loss. I'm going to be joined by Dr. Tyna Moore. She's a good friend of mine, and we're going to talk all about Ozempic and its sister medications, and we're going to talk about microdosing it and some pretty surprising findings of what these peptides can do for you. Okay, so let me introduce my guest this week. Her name is Dr. Tyna Moore. She's an expert in holistic regenerative medicine and resilient metabolic health. She's licensed as a naturopathic physician and a chiropractor, drawing on knowledge from both traditional and alternative fields of science and medicine to provide a comprehensive perspective to individuals striving to enhance their health and well-being. Her work is not just about treating symptoms, it's about understanding and healing root causes to build a robust foundation for long-term well-being. She's also the host of the Dr. Tyna podcast, which is one of the top health and wellness podcasts in the country. And I have been a guest on it in the past. So I'm really excited to bring this podcast to you because I get so many people ask me about Ozempic, about Wegovy, about Mounjaro, and these associated medications. How are they used for weight loss? Do I recommend you use them for weight loss? And we're going to get into the nitty gritty about these medications. You're going to understand everything you need to know about them, and microdosing, which is a whole other way of looking at them and how they can affect your health, not just with weight or with your blood sugar, but your brain, your heart, and your other organs. So this is going to be really interesting. I'm so looking forward to bringing you this podcast today. So let's get started. Well, thank you so much for joining me today, Tyna.
Yes, thank you for having me. I'm so excited to be here.
So this is a topic that is, everybody's talking about the GLP-1 agonists, whether you're talking about Ozempic or it's, it's twin, Wegovy, it's the same thing, or Mounjaro, Zepbound, all these types of medications that are so hot because people are using them for weight loss. Today, we're going to be talking about that, but we'll also be talking about some novel, interesting uses that you are doing with it. But I'd like to first start out by getting a little bit of your story. So you are one of the country's foremost naturopathic doctors who is focused on longevity, on regenerative medicine, metabolic health. How did you decide to go into this direction with your career?
So far as the Ozempic story goes?
No, so far as
my
before
whole
the
career.
Ozempic stuff. Yeah, we'll go into that next. But yeah,
Okay.
Your career before the last, couple years where Ozempic has been such a huge part of it. You've been in practice for many, many years. You've been doing this for a long time.
A long time. Well, I was fortunate enough to find a mentor way back in the day. When I got out of undergrad in the early 90s, I was interviewing for jobs. I was living at home with my parents, and I interviewed for a position with a naturopathic doctor in my little suburban town where my parents lived. And it turns out he was like a complete rock star in our field. And his name was Dr. Rick Marinelli, and he was young and he was fit and he was doing really cool regenerative medicine, chelation, all kinds of cool therapies. And I just thought this guy was a magician, He was an acupuncturist, a lot of physical medicine, just really a high level Jedi practitioner. And I had the honor of following him around for 20 years. So I adopted a lot of his practice ways and I learned a ton from him, realizing in these latter years, what I learned from him still really in many ways isn't entirely catching on, with the more mainstream doctors. And I didn't realize how much he had taught me along the way. And then I took a turn and went through chiropractic training as well as naturopathic college. And so I got both degrees. And so I have a big physical medicine background, and my practice was predominantly regenerative medicine. So helping people using natural substances to get their joints back and, keeping active people active so that they could not be nagged by shoulder and knee and spinal pain. And a lot of that had to do with different regenerative substances that we had available, many of them coming from the patient's own body, like PRP, stem cells, and then later on peptides, et cetera. And so it's been just a long journey. And at the core of all of that always, for what Dr. Marinelli taught me and what I taught my patients, was metabolic health. You just can't regenerate if you are metabolically unsound and your insulin's all over the place and your blood sugars are everywhere. So as you know, it doesn't help the skin. Well, it doesn't help the joints either. So that's where it all kind of came full circle for me. And then throughout the last few years, I've really been beating the drum on metabolic health during the pandemic and lockdowns, just trying to help empower people to take their health into their own hands and really optimize their metabolic health so that they wouldn't be so susceptible to illness. And that's kind of where, it brought me into stumbling into this Ozempic story. It was really just a lot of the clickbait headlines and even the functional medicine community getting behind this narrative. It just all really started sounding propagandized to me. And so that's where I dug in.
So before we get into the GLP-1 agonists, can you just, define for my audience what you mean by metabolic health or being metabolically healthy?
Sure. So at its simplest form, the foods we take in should be metabolized in a certain way in our body to optimally be used for fuel and for substrate to build the things we need to build. So the fats and the carbohydrates that come into our body and the proteins should be assimilated in a healthful way to helping us regenerate our tissues at the end of the day. And unfortunately, way back when my mentor was talking to me about metabolic health with patients, and he was doing screenings with lab work and looking at waist circumference and other things. And this is decades ago. And it was a bit of a mess. Like I could see humans really going in a direction that wasn't great. And so when I went into practice in the early 2000s, I was screening everybody for metabolic dysfunction. And the term syndrome X was popular when my mentor was teaching me. And then it turned into this sort of metabolic syndrome that they call it. And I was screening everybody for that. And I was actually catching a lot of slack from my profession because they were like, oh, Tina thinks everybody has metabolic dysfunction. And I'm like, I'm literally finding glimmers of it on everyone's labs. Like almost everybody that walked in my office had some glimmer of either the beginnings or they were in the throes of it. And what people don't realize is this pre-diabetic state should be its own classification, right? I call it phase 1 diabetes because it's this preliminary phase of 10 to 15 to 20 years before people are diagnosed with type 2. But a lot of damage is happening during that period. And that can be dialed back through lifestyle pretty readily. And it's low-grade insulin resistance. It's where the cell's not uptaking glucose the way it should. Root cause of that often is being under-muscled, ultra-refined carbohydrates as the predominant source of calories in a person's diet, not getting enough movement, not doing all the things that, you and I both talk about. And it's leading the American public into a real mess. And now it's a worldwide phenomenon. And interestingly, 2018 data showed that roughly 94% of US adults had busted cardiometabolic health. So those who were making fun of me back in the early 2000s, I'm like, well, here we are. So it's really pickle. And unfortunately, doctors aren't taking it seriously. I think they're starting to see it, but you get the sequelae of fatty liver, which has been normalized. You get lipid changes. So cholesterol, triglycerides start to change. And they're like, oh, here's a statin, not addressing the root cause. And at the core of this is the fact that people's bodies are not utilizing food optimally as fuel the way that it should be.
The hottest topic really in health is Ozempic. And everybody thinks, Ozempic is kind of like the Kleenex, it's the brand name of GLP-1 agonists. So let's proceed in talking about that really is the subject of the podcast today, because you have become one of the foremost experts throughout the country on this peptide. It's not technically a drug, it's a peptide. Let's start by asking you to explain what a GLP-1 agonist is and how it functions to help people lose weight. And I know we're going to talk about some other functions of it today as well, but let's start by just kind of the weight part of it, because that's what everybody's talking about right now.
Sure. So a GLP-1 agonist is a naturally occurring substance in our body. It's produced endogenously. It's produced in the L cells of our gut, and it's also produced in our brain. And we have receptors throughout our entire body for it. But what it's most notably known for is the fact that it can induce regulation of insulin secretion. It reduces glucagon, which ultimately is going to lead to improved blood sugar handling in the body and more optimal metabolic function in the body for the individual using it, which is ultimately going to lead to weight loss in and of itself because we're getting insulin in check. The other part is that it has an impact on the brain to regulate, and it works with other signaling peptide hormones, which this is a signaling peptide hormone. It works with the others like ghrelin and leptin to have an impact on appetite. And so it's perceived, decreased appetite. The person doesn't want to eat as much. And then it has an impact on the gut directly by slowing gastric motility, and which allows for someone to feel fuller longer. So that's the endogenous natural version. And then it works in the brain. There's several mechanisms happening in the brain that we don't entirely understand, but it's working on reward pathways up there and all throughout the body.
So I think the general public, they look at Ozempic, they look at Wegovy, they look at Mounjaro, and they look at these as pharmaceutical medications. In reality, that's not quite the case. Can you explain the difference between a true pharmaceutical medication and what Ozempic, technically these GLP-1 agonists are?
I'm not a pharmacist, but I do understand pharmacology decently well, and I have a license to prescribe. And I used to teach pharmacology, actually, just kind of the 101 version to the chiropractors in the chiropractic college. And what I understand mostly with pharmaceutical medications is that these are synthetic substances that oftentimes mimic natural substances, to be honest with you. And they have a binding to the cell. They have an impact on the cell, and they change pathways in the most simplistic terms. They have a direct impact on changing pathways. And sometimes these are blocking pathways that are necessary. Sometimes these are inhibiting bacteria from replicating. It might be working on the cell wall. It might be working in the nucleus. Peptides, on the other hand, they've been known in the biohacking community and in the regenerative medicine space for a long time. And they are strings of amino acids that are peptide bound to each other. And that creates a peptide. And a string of peptides is what makes up a protein. So peptides insert themselves where they need to go. Similar fashion, they'll bind, they'll go into the cell, they'll do their thing, but they insert themselves where they need to go in more of a regenerative, healing, and oftentimes anti-inflammatory fashion. And what happened here is, I believe, the pharmaceutical industry basically co-opted this peptide, which is the GLP-1 agonists or peptides. They've been around for a long time, 20 years. They've been in use with lots of safety data. There's just different generations of them. They're just getting fancier as they grow up, with tirzepatide being the fanciest on the market right now. They have the route of being an injection. And so that warrants them being a prescription item. And that's where we are in this. And so semaglutide, for instance, is bioidentical to the GLP-1 that is secreted by our body, with one caveat. The GLP-1 secreted in our body naturally, endogenously, has a really short half-life. And so it's just in and out really quickly. And sometimes it doesn't linger long enough to be really effective for the body individual. But the semaglutide has a tweak on it so that it has a longer half-life. But otherwise, it's pretty close to the original form. And so it's different there. I don't know if that explains it well, but peptides are a different beast.
I think it does, because I think a lot of people don't realize that, people think, oh, if I have this Ozempic, if I have semaglutide basically injected, then it's like if I'm injecting an antibiotic, or if it's like I'm taking a statin drug, it's just another drug that I'm taking. And I think a lot of people don't realize that this is a peptide. This is a protein that is naturally occurring in your body. This isn't some synthetic medication that you take that's going to alter your body's processes in an unnatural way. This is basically just replenishing a protein that is present already in your body, but now it has been altered so that it can, as you said, have a longer half-life, essentially meaning that it can last longer in your body and create its effects. So that's the GLP-1 agonists. And so those are the ones that people talk about. Ozempic, which is the one that's FDA approved for type 2 diabetes patients, and then Wegovy, which is the one that's FDA approved for weight loss. The same medication, or the same peptide, essentially, just two names for the same thing. And then people are also getting it compounded. The generic name is semaglutide. What is the difference then between the GLP-1 agonists, like the ones I just mentioned, and tirzepatide, which is a kind of a different category? I know it's a little different. It's got a little more to it, but how do they function differently? And how would somebody decide which one would be best for them?
Well, before I get into that, I want to say one thing. I do think that when you take something like a peptide and you crank the dose way up, which I know we'll get to dosing conversation in a minute, but when you crank it way up, you start getting into pharmacologic changes versus physiologic changes. So that's where I think a difference lies that we can talk about. But that's how I look at hormones. That's how I look at everything. It's like, where's the physiologic need? And then when we're cranking something so that we really do start pushing pathways at very high doses, I think that's when we can get into trouble. So I think it could be used either way. Okay, so semaglutide is just a GLP-1 agonist, meaning it binds this receptor, the GLP-1 receptor, and it behaves as GLP-1 would. Tirzepatide is a dual agonist. It's a GIP agonist and a GLP-1 agonist. So GLP-1 basically causes insulin to surge and secrete as needed more appropriately, and it reduces glucagon secretion. GIP actually promotes glucagon secretion, which seems like an oxymoron. And I've dove deep into this, and I've listened to so many webinars with the scientists who've who've developed these peptides and who are studying them and who've done all the studies on mice. And it almost seems like GIP, we could agonize it or antagonize it and we still get similar impacts. And so tirzepatide just happens to be a GIP-1 agonist. And when you start tweaking with the GIP, you get a more profound impact on blood sugar handling and on metabolic health and metabolic healing. And so it's just a little bit of a different beast. And who needs what? It kind of depends on what you're going for, what your short-term and long-term goals are with these peptides. And then also tirzepatide seems to have a more comfortable side effect profile, although I don't dose patients up into side effects, but it does seem to be handled better by some people. And in other people, they say, oh, it gives me a little bit too much indigestion. I don't like that. And so kind of different beasts. And I've even noticed a different impact on overall, I'm using it more of an anti-inflammatory fashion and more for like autoimmune conditions. And I'm noticing a little bit difference depending on the patient on which one's better. And cost can be a difference too.
Being a naturopathic physician, I'm assuming some of your colleagues may have questioned that, okay, here you are recommending an injection. You think, okay, I'm a naturopath, I'm into natural medicine. Are there natural ways that people can bypass these injections and, eat certain foods or anything that can help to get a similar effect?
So I think that adjunctively, there are ways to support natural GLP-1 secretion. However, that said, these are secreted predominantly in the gut, and most people's guts are a mess, as you well know. And so when you've got an inflamed gut or a leaky gut, which most Americans seem to be dealing with some version of either IBS, there's inflammatory bowel disease, which would be more like the Crohn's and ulcerative colitis. I mean, even my daughter, she's 24 and she's like, Mom, all my friends' guts are so messed up. That's the true epidemic, right? And so asking a cell that's maybe petered out, or perhaps it's atrophying due to age. That's another factor that nobody's really talking about that I think about. It's like as we get older, our gut lining atrophies. So trying to get the L cells to go is the goal. Obviously, we want to do both. It's not one or the other. So a food bolus going through the gastrointestinal tract will just mechanically stimulate it. So just eating enough in a sitting instead of sort of grazing all day long on small little tidbits, like getting a meal and a meal in instead of, 6 little tiny snacks. I think that can be helpful. Glucose itself actually stimulates the L cells. Bitters will stimulate the L cells. So bitter herbs like berberine. Now, these are all helpful, but there's not a nature's Ozempic. Like it's not the same thing. Stimulating the L cell to go is a whole different beast than actually having an agonist sit on a receptor throughout your body and do its thing. So it's not the same thing, but we certainly don't want to throw the baby out with the bathwater. There's sodium butyrate, I think, has good data behind it on helping to trigger the L cells to actually do their thing. There's different, Akkermansia probiotic has a roundabout way of getting the L cell to, via sodium butyrate, getting the L cell to go. So it's not one or the other in my mind. It's adjunctive. And depending on patient needs, if a patient is using a GLP-1 agonist and they have gastrointestinal issues, I might choose some of those substances that I'm very familiar with in naturopathic medicine, like berberine, sodium butyrate, some of the other herbs, fenugreek, to get the gut happy. So it kind of depends. Some of my colleagues were suspect, but I've always been using pharmaceuticals. I have a license to prescribe and I'm not afraid to use it. And I'll just say this, the way that I was trained by my mentor, and this doesn't jive with everyone, but I think most people can appreciate this. Sometimes we need some pharmaceutical intervention and some help. And oftentimes the lifestyle's down here. And so, my hand that's in the air for the people listening to this on audio, it's like people come in on a lot of pharmaceuticals and their lifestyle's kind of in the dumps. My job is to get their lifestyle improved. And it's like a teeter-totter, which will bring down the need for the pharmaceutical. So we can get it to the lowest dose necessary to get where we need to go. But I'm not afraid to use it, even when it comes to maybe a statin drug or an antidepressant. I'm not afraid to use those either, but I ideally want it at the lowest dose possible. So we're getting the impact and the improvement, but not the side effects. And in the meantime, the patient's working on lifestyle to really optimize all the things. And that's, I think, a really beautiful way to combine holistic medicine, functional medicine, along with allopathic medicine. And that's the way I've always done it. That's the way I continue to do it. I do that with hormones. I do it with all kinds of pharmaceuticals, and patients usually appreciate that.
And I think, it makes a lot of sense. What you're talking about is a nuanced approach to health and not being extreme, of all pharmacology or all lifestyle, and understanding that everybody comes in it from a different place. And it's trying to dial that in for where they're at to try to get them where they want to be. We don't all start in the same place. And it makes complete sense. And I applaud you for your approach to it. So where you have really made a lot of headlines and you've been on a lot of podcasts, a lot of people are talking about you, is because you have brought up the topic of microdosing of these medications. So just for those people who don't maybe know how these medications work, there is the prescribed, the recommended dosing of these medications, just for example, with the semaglutide. So if you have a doctor who's going to put you on Wegovy, which once again again is the semaglutide is a generic name. Wegovy is the brand name for the FDA approved for weight loss GLP-1 agonist. If you're an adult or children 12 years of age or older, you want to start with 0.25 milligrams once a week for 4 weeks, and then they may increase your dose every month or so, maxing out at about 2.4 milligrams. And so this is kind of the normal dosing. But what you have talked about that has gotten a lot of physicians, a lot of healthcare practitioners really interested is the idea of microdosing these medications, not following these FDA approved protocols, because, you could be really injecting a lot of this peptide into people, but looking at microdosing it in much smaller amounts. How did you come about doing this? What are some of the benefits of the whole idea of microdosing these versus giving the FDA recommended amounts that most doctors are doing nowadays?
Well, I looked at it and I started researching it about just over a year ago. I started researching GLP-1 agonists in general and their impacts throughout the body. And I found out that they're neuroregenerative, they're cardioprotective, they are protective to the pancreas, they help regenerate the cells of the pancreas that secrete insulin, which oftentimes gets burned out in a lot of individuals. They are protective and healing and regenerative to muscle tissue, to joints, to bones. It just really, I was blown away. And I was like, well, then what the heck is going on? So insulin is a signaling peptide hormone, for example. And if you crank somebody out on high doses of insulin, you will kill them. And I thought, well, I think this is just common sense. I think they're just dosing people too high. I think this dosage schedule is crazy. Oftentimes those doses are being almost doubled every 4 weeks. And that's what the studies did. The studies took people up to 2.4 milligrams and then looked at the side effects and the serious side effects and the minor side effects. And by the way, the side effects are not nearly as gnarly as the media has been leading us to believe. So that's an interesting conversation. But the way that I've always done medicine was exactly what I just described earlier, that teeter-totter. And I was like, I use hormones in the lowest doses necessary. I do not always follow the algorithm of how you're supposed to dose the estrogen or the testosterone. I dose until symptom alleviation. And since my practice completely revolved around pain and musculoskeletal complaints, it was really easy to gauge when symptoms were being improved because most people were having pain as their cardinal symptom. And so when I would get that pain down, that was the dose. That was pretty easy, right? I didn't have to go by, we're looking for let's take a menopausal woman. We're looking for improved cognition when we're using estrogen and progesterone. We're looking for hot flash alleviation, whatever it is. I mean, hot flashes are kind of last on the list. With testosterone, erectile dysfunction is kind of last on the list. You're looking for these other symptoms that are pretty common. And so I would dose until I would get results and then I would back off. We monitor with labs. And that's a really safe and effective way, I think, to do hormones. And so I looked at it from that perspective. I was like, wait a minute, maybe they just need some physiologic doses of GLP-1 because of the reasons I described. Maybe their gut lining is just burned out. Maybe they came out of the womb with some issues. I don't know. We don't know. We haven't looked that hard at what actually being born from a mother who is metabolically dysfunctional and the baby is swimming in a bath of insulin for 9 months in utero. We're not looking at their GLP-1 levels, but I started thinking, I wonder if people either have a functional deficiency that came on through a life of whatever. I mean, like you said, how did they come to the situation? How did they present? What was their life like before that? Or is there maybe even some potential? This is a hypothesis. I've been taking a lot of heat online for this, but I have a hypothesis that I think some people might be a little bit GLP-1 deficient for various reasons. Or we're not all secreting the same is a better way to say it, right? And so we do have data showing that those who are dealing with fatty liver and or type 2 diabetes have a low level of GLP-1 and those with obesity have a low level. So erroneously say deficiency, and maybe it's not exactly the same thing, but by definition, but these folks are presenting with really low levels of GLP-1. Did their lifestyle get them there? Did the obesity get them there? Did the high insulin levels? Yes, all of the above. It's kind of like a chicken and egg. But I got to thinking, I wonder if we use these in small doses for individuals who maybe don't have metabolic dysfunction, or maybe they have low grade metabolic dysfunction, but they've got a cardinal list of other cardinal symptoms. So that maybe they've got cardiovascular disease and we could use them protectively and preventatively because my business is preventative medicine. I'm not waiting for them to have a heart attack before I apply a therapeutic, right? Maybe we could use it for brain fog, for neurodegeneration, which was what it was originally studied for. Maybe we could use it in really tiny doses. What would happen? So I started playing with it with myself and with my patients and got a whole bunch of my colleagues actually sort of playing with it on their own in their clinics on themselves and got all the feedback. And it's just been really interesting that when people are particularly metabolically sound, like someone like you or I, like we're doing all the things, we strength train, we exercise regularly, our sleep sleep is pretty dialed in. We eat really well. We're doing all the things. I found that a small touch of GLP-1 agonist can have really remarkable benefits. And for me personally, this was really a personal journey. I was dealing with some pretty severe brain fog that came on, perimenopause, COVID I had post-COVID brain fog, which a lot of people do. And then I have psoriatic arthritis, which induces a tremendous amount of inflammation in the brain and causes a ton of brain fog. And it was impacting me physically. It was impacting my spine. It was impacting my skin. It was impacting my brain. And I was just really in a pickle. And everything that I know to do with regenerative medicine, I have access to all kinds of cool stuff that you probably know about, exosomes, things like that. Nothing was cutting it. And I could not get out of this loop I was in. And I put on about 15, 20 pounds from stress. It was just happening. And I was like, oh my gosh, this middle-aged thing that I used to see walk into my clinic where women who were always fit and healthy and lean would walk in and say, Doc, I just gained 15 pounds out of nowhere. It's all in my midsection. What the heck happened? I haven't changed anything. And I'd be like, oh, it's happening. And I watched it happen to all my family members, and it started happening to me. And with it came a tremendous amount of pain. I do think some people's fat tissue, adipose tissue, is more inflammatory than other people's. I come from a family where you gain weight and you hurt. And I thought, you know what? I'll give it a try. I mean, what can it hurt? A small, tiny dose. Let's see what happens. And I'm talking a fraction of the starting dose. And that dose is different for everybody. So I couldn't give you a clear answer. And like, everyone wants to know, what's the dose? It depends on the patient in front of you. But a small dose for me might be different than a small dose for my patient or my family member or whomever else. And it just has been really remarkable. And so I started applying it for different conditions. And I shouldn't say conditions, just different presentations, different symptom pictures people were having, and remarkable, like just really remarkable impacts for people. Really, the answer when people say, what's the dose? I say, it depends. And we keep it just this side of symptoms. So we don't dose into symptoms. And it's the highest dose necessary to get the individual the results they need. Sometimes I have to bring on other peptides, hormones, other things. This is not a one-shot wonder. It's not a monotherapy magic cure-all. We use it as a tool, as part of a comprehensive toolbox, but it's been really remarkable. And so I started talking about it and it all just kind of blew up. And then here I am.
So you start yourself on microdosing a GLP-1 agonist. What specific changes did you see in your body, in your how you functioned, and how long did it take for you to see those changes?
I immediately felt my anxiety leave my body, which I didn't even realize was there until it was gone. And I was like, that's nice.
Really?
Yeah, it was very quick. And many people have reported that. They don't even notice that they notice it until I ask them. I'm like, how's your anxiety? Well, I didn't have anxiety. Well, do you feel calmer on it? Actually, I do. Do you feel more clarity? Actually, I do. So a lot of cognitive benefits I'm seeing. Mood boost. I'm using it personally to have that antidepressant impact, if you will. It's not a FDA approved antidepressant. So people out there don't misunderstand me. But for me, it has worked in a fashion. I've taken antidepressants and it's worked in a really wonderful fashion to boost my mood, help my cognition. Predominantly, that's been the best part. And then on top of it, all my autoimmune symptoms just leave the building when I'm using it. And so my psoriasis cleared up completely. And other people have reported that as well. My pain is way down. And a lot of other people have reported that as well. A lot of people reporting like, oh, all my joint pain is gone. I didn't even realize I had it. Just kind of like this low grade naggy pain. We learn to live with pain because our brain down wires our perception of it, so we can endure it. But that just kind of leaves for a lot of people, not completely, not always. And there might be flares in between, but significant improvement. And then for me, my mobility improved. I was going through kind of a gluing together because of the psoriatic arthritis. My spine was starting to fuse and I've got near full mobility now. And I'm much more active than I was before without getting all these little naggy injuries that I was getting because I was so locked up. So that's just for me, mainly where it's been. My menses is regulated out better. I was starting to get some perimenopausal shifts in my menstrual cycle. It's gotten much more stabilized. I can't think of anything else that's most notable.
How about weight?
Oh, yeah. Weight? So I had, like I said, I'd put on, 15, 20 pounds. This is what I noticed for everybody on the low dose. It just takes the fluff off. So I still have a little bit of a belly. I still am built the way that I've always been built, unless I'm really, really trying to get my body composition in check. I tend to carry a little bit of a belly. I am right back to where I was 2019 before all the stress started, before that weight came on. And that is exactly what I've noticed for everybody doing it in very low doses, to the point where some people are frustrated. They're like, I want to lose more weight. I'm like, well, you either have to bring some other adjunctive therapies on board, or you have to really dial in your lifestyle. Like, are you lifting 3 days a week? Are you walking 30 minutes a day? Are you sleeping? Are you doing all the things necessary for optimized metabolic health and weight loss? And they'll say, well, no. Okay, well then cranking the GLP-1 dose is not the answer. Do the other things first, right? But if they want to crank the dose and go into symptoms, they can and they'll lose weight, but that's not what I'm going for. So I have not cranked anybody into symptoms. And if we do, we back right down. We don't want symptoms. We don't want nausea or feeling, sick at night or definitely no vomiting. We don't want any of that. So the fluff kind of came off and everybody's just at their fighting weight, as I call it. Everybody just dropped back down to kind of where they were. And if we want to dial that in, there's other peptides and there's other resources for that.
So from your experience, and I think we have to always mention, in this situation, we're not talking about peer-reviewed studies. We're talking about your clinical experience with the people that you have it on. So all the things that she's saying here are, you take it for education, but not,
yes.
She's not your doctor here.
No, I'm not. And I'm not telling anyone how to do it. I'm just telling them how I've done it.
So what you're seeing is that you feel that a lot of these symptoms, side effects that people are worried about, pancreatitis, nausea, vomiting, those types of things are really pretty dose dependent. And that where we're going wrong with the dosing of these GLP-1 agonists is that we're just giving too much. And if we were to dial those doses down into the microdoses, you may be able to get a fairly similar effect, but at the same time, avoid a lot of these side effects that people are worried about.
Yes. And I will say this, I am realizing, because I've got a decent sized platform. And so getting a lot of feedback from people all over the world. And for some people, a microdose, quote unquote, is actually the standard starting dose. Some people do not respond. If they're severely diabetic or have a lot of weight to lose, they're going to probably need much higher doses. This strategy is reserved for those who are already metabolically sound. I want to be very clear about that, because people have heard me on podcasts decide to mess with their own dosages. Don't do that, people. Do not follow your doctor's instructions. I'm not telling anybody what to do. In fact, I highly discourage that, because you can get into trouble with these. But though they've lowered their dose and they're like, well, it's not working. I'm like, well, not working for what? Like, if your goal was weight loss, I was real clear. This is not a weight loss strategy. So I want to really drive that home for people, because they're hearing whatever they want to hear on these podcasts. They get excited and hopeful, and then they hear me say things, and then they make up things. And that's not what we're getting at. So what was your question originally?
So it's basically just about the side effects. That if you dial it down, and possibly you could prevent a lot of these side effects. That, one of the things that people are worried about with these is the side effects, obviously.
Yes. So let's talk about those. So the pancreatitis, I think, is a real risk. The number one cause of pancreatitis is throwing a gallstone and or fatty pancreas. And so I think when we're looking at the side effects in the general population, taking the higher doses of those people are already sitting on the edge of a lot. They are already predisposed, significantly more predisposed than their lean counterparts, to have all of the things that you're hearing about. So in the case of pancreatitis, they're already sitting on the edge of pancreatitis because they've probably got some biliary issues in their gallbladder. And it's real easy when you go super low calorie, super fast, which I don't suggest people do. That's a dosage problem. They will potentially throw a stone because their gallbladder sludges up, and that stone gets thrown into the pancreas. And now you've got pancreatitis, which is a real issue. Like, that's a really bad thing you do not want. So I do think that's a real concern. And anybody with a history of biliary disease or gallstones should be very, very careful, even if they're lean or even if they're doing a tiny dose. Like, they should be very careful. The gastroparesis, the group most susceptible to gastroparesis is type 2 diabetics. It's because of the hyperglycemic impact on the vagus nerve. It's being destroyed slowly but surely already. And then they're cranked up on these high doses, and they go into their stomach basically seizing up on them. But that's been shown in the data to reverse itself once the GLP-1's out of the system in a few weeks. So it's not permanent. I haven't seen any cases where that's been permanent. I'm not saying they don't exist, but that's not a real big potential to have a permanent gastroparesis. But a type 2 diabetic is most at risk for that. Some of the other concerns, the muscle loss, any severely low calorie diet is going to induce the same percentage of lean mass loss, and they're clumping muscle into the lean mass measurement. And so that's a bigger conversation, but these actually are muscle regenerative. They actually help perfuse the muscle with better capillary fill, and they help potentially bring in more amino acids for muscle protein synthesis. So that's almost like an anabolic impact on the muscle. It's not degradatory to the muscle. That's not how these act. So that's not the peptide. That's the severely low calorie diet that's inducing the lean mass loss. And if these individuals aren't being counseled to or not being compliant with, which is often the factor, with strength training and prioritizing protein in their diet, especially if their appetite's being crushed, they've only got so much room and so much appetite. If they're just eating, a bag of potato chips or whatever, eating less of the potentially garbage food they were already eating, I'm not trying to vilify anyone, but people are admittedly, junk food addicts, and they're like, well, I'll just eat less of the same thing. That's not going to cut it. And you will lose lean mass. And that's a mess down the line. Those people, I think, are going to be worse off than than when they started. They're going to end up ghosts of themselves with no muscle. And that's a metabolic disaster. Some of the other ones, the thyroid cancer, there's a black box warning for thyroid cancer. That was on rats. And those studies were interesting in that this is a type of cancer that's very rare in humans and very common in rats because they have a different receptor in their thyroid that will bind. And so they were developing spontaneous medullary thyroid cancer. And so was the control group. And they were given very, very high doses of GLP-1. So in humans, we don't see this as often. And the data that's coming out right now is really just saying, like, we've looked at it, we've looked at it, we've looked at it, we've looked at all these studies, we've looked at all of these chart notes, and it just doesn't line up. We're not seeing an increased risk for thyroid cancer in humans. So that's still ongoing, of course. But if you have a history of any type of thyroid cancer, particularly medullary thyroid cancer, or it's in your family history, of course, you're probably not a candidate for these. So be careful there. And the kidney issue, it's regenerative to the kidneys. They had to stop the FLOW trial at the end of 2023 because they wanted to ethically be able to give the control group the peptide because it was so impactful on chronic kidney failure. So we hear these like clickbaity random one-off stories where somebody takes a super high dose and vomits themselves into some kidney damage. And so then it causes kidney damage. It's just not true. My mom sent me an article yesterday and it's just lies and really propagandized levels. So people are going around saying 80% of people are having severe nausea. That is not true. The studies consistently are showing about a 20 to 25%. And that's at the high doses having transient nausea, not even severe. So it's just not lining up with what we're being pumped. And I'm not really sure why this push.
I was about to say, how much do you think this is becoming in some ways a war between big pharma, Novo Nordisk, who basically creates Wegovy and Ozempic, and big food where, if people are eating less, then they're making less money.
Yes.
I mean, do you think that has,
Yes.
I know you're a little bit of a conspiracy theorist.
I'll put on my tinfoil hat.
Do you think that that's really going on? And I'm sure you have no guessing. I'm assuming you don't have any solid proof.
They've said it.
You think there really is a war that they're literally fighting each other, where you've got one big pharma where they're making an unbelievable amount of money. They're saying that Ozempic is going to be like the most money-making drug in the history of humankind, versus big food where they're thinking, oh my gosh, like people are actually losing weight. They're eating less food. They're losing, the desire to eat all these ultra-processed foods. Do you think that really is going on?
I do, because big food has come out and said, like the CEO of Cheez-It said, we will watch this carefully. And now big food has come out and essentially said that they're going to create a line of products that are in alignment with GLP-1 use. So, kind of like the Weight Watchers and the Atkins had their own food line. It's going to be like that. Like they're getting in line with GLP-1 friendly, highly processed packaged food. So yes, I think there's a lot of industries that have something to lose. What about the dialysis clinics that are popping up on every corner in America and the suburbs? I don't know if it's happening in your part of the country, but there's a lot of dialysis clinics and mini malls around here because type 2 diabetes is very profitable for a lot of industries. And they were potentially concerned. I know for a fact, because I read, I think it was in Forbes, the joint replacement companies are concerned. That's a very profitable industry when you're dealing with a life of obesity in an individual. So I wonder also the big pharma companies who don't have a GLP-1 patent yet, are they, I don't know. I'm just speculating. I know big food is concerned. McDonald's has said something. It also, here's the other part, because it works on the dopamine reward pathways and the serotonin pathways, it impacts on alcohol cessation, smoking cessation, drug use. It's actually making people want to do those less. And so many people are reporting, and I've even got a patient on it, who they just don't want to drink when they're on it. And it's being studied for alcohol abuse syndrome. So there's a whole industry there. There's a couple industries there that might have something to lose. If people don't want to drink and they don't want to smoke and they don't want to eat crappy food,
A lot of businesses are going to have major financial issues.
Yeah, it's interesting to think about or speculate.
So one of the things that honestly really irked me is that I know plastic surgeons were advertising semaglutide injections. Essentially, they get it from compound pharmacies. And this brings me back to several years ago when weight loss balloons were a big thing that they were marketing to plastic surgeons. I think because we tend to want to do invasive procedures that make us easy money, and that we ideally don't want to have to do a follow-up with patients. So I know plastic surgeons who are advertising semaglutide injection. Some of them were early on when it was very short in supply. And so they were getting it compounded. And it irks me because, I go to our meetings, like plastic surgeons don't know anything about lifestyle and preventative health. Like we're not trained in any of that at all. As much as we think because we're an MD, we know, we don't know. And the only reason why I know is because I've spent thousands of hours studying it on my own. And so it bothers me because I do see my colleagues who are advertising this. I think it's a pure and blatant money grab. grab. They're not doing it necessarily for the benefit of the patient. Now, there are some who may be doing this out of weight loss centers, obesity clinics, like, okay, that's great. I think that the big thing is if you're going to do this, you need to follow these patients up. You need to help them with lifestyle modification, because ideally you don't want to have them on these large doses of these peptides and having to have them pay all this money every month for the rest of their lives. I saw one plastic surgeon on social media answering a question of like, how long do I need to be on this? And he said, you should just be on it for the rest of your life. Well, then that makes this doctor a lot of money every month for the rest of his career. So the question that I have for you is that what would a plastic surgeon be missing if they are treating somebody with these medications as far as educating patients regarding lifestyle? I know that we touched on it a little bit ago, with strength training, but can you explain kind of what specific things that patients, maybe if somebody's listening today and they've got a doctor who's injecting them with semaglutide every week, but they don't say anything to them about lifestyle, what are some of the things that they should consider so that they can, number one, thrive, number two, get the result they're looking for, and number three, hopefully be able to reduce the amount that they have injected in them as they, do better and better? What are some of these lifestyle things that they need to know about?
Well, I'll quickly just say around the dosing, I think the allopathic community is starting to catch on that we just simply don't need to take people up to that 2.4 milligrams. Like we don't have to go there, And so there was a group out of Italy that just presented a paper talking about how they're having great success with personalized dosing, which is similar to what I'm trying to talk about, but they're using much higher levels, getting people to the dose where they're getting impact. And I know a lot of smart doctors using it this way, right? They're using very small doses and they're getting people the results they need. Maybe not the micro tiny doses that I'm talking about, but they're using low dose. Then you titrate them off. You slowly taper them off the drug. And that is showing, a paper was just presented. I don't know if it's been published yet. And I think it was the European Obesity or Congress on Obesity. They showed that for the 9 weeks that they tapered them off, they maintained weight loss. And then they even lost further weight and maintained weight loss for 26 weeks beyond that. That's as far as they followed them. So they're starting to catch on that you don't just crank up the dose and then drop it and then it's gone. That's not how you do it. And I don't think anybody should do that with any hormone or any peptide, especially if they've got the dose high. So not getting the dose high, I think, is number one. Number two is doing all the things. So really prioritizing your muscle mass, which we should be doing anyway. You know me, I've been beating that drum for a long time. I've been telling people to eat steak and deadlift for as long as I can remember even being online. Like that's what I came online with. And it wasn't popular then because everyone's like, go vegan and do yoga. So really optimizing your muscle mass, that is your insurance for your future self. That's it. Like this is how we fully optimize our metabolic health. Keeping a tight check on your metabolic health, right? Like that's a whole thing in and of itself, but just keeping a check on your waistline and your waist circumference and making sure that it is less than half of your height. So just taking your height measurement in inches or centimeters, having that, and that's your red flag zone. You want to be below that always. Making sure you're optimizing your sleep because that'll destroy your metabolic health. So getting that in line, that might take some hormonal therapy. That might take some other things, right? That might mean that you have to prioritize exercise during the day so that you're worn out at night appropriately. Like children and puppies, we adults are the same. We need to have that exercise during the day. Making sure you're getting adequate light during the day and really setting your circadian rhythm. So you're getting morning sunlight, you're getting midday light, you're getting afternoon light or sort of that sunsetty time. Your eyes are seeing it happen and hopefully you're outside in it. That's going to do really wonderful things for your daytime and nighttime health. And making sure that you have some stress management in place because chronic elevated cortisol will destroy you. It'll destroy your metabolism. It'll destroy your insulin sensitivity. It'll destroy your hormones, literally turn your ligaments and tendons and joints to goo over time. And so it is catabolic and it is not great. And so making sure that we have a check on how we go about managing our stress. And that might mean some lifestyle changes. That might mean some job changes or some marital changes. I don't know, but people do not appreciate what stress is doing to them. We live in this country where it's like, you're my age, we went through the whole period where it's like, don't sleep and handle as much stress as you can. And you're a hero for it, and I think that just was a really damaging message. So those are some of the top things that I would say that all humans to human the best they can, GLP-1 or not, they have to do those things. And I don't think most doctors, it's not just plastic surgeons, most doctors don't have a clue how to deal with metabolic health. Most naturopathic doctors and functional medicine doctors really don't have a clue. If someone doesn't lift weights, I'm like, dude, you're not even lifting. why do I keep getting letters? Why do my patients keep getting letters saying your lab results were normal? You have a little fatty liver. I'm like, no, there's no such thing as a safe little fatty liver. Like we're normalizing these degenerative conditions in humans. And it's just been this slow trajectory during the course of my career. And there's just no safe level of metabolic dysfunction. We got to get that dialed in.
So ideally, if somebody is taking Ozempic or one of these medications for weight loss, is the goal eventually to just have them on a very, very low dose? Or would the goal be to eventually get them so metabolically healthy, getting them to change what they're doing in their lives that we can get them off of it?
I think it depends on the patient, because what I'm finding is I only have one patient on it for, we got to get some weight off this fellow. His cognition is so greatly improved and his mood is so greatly improved and his humor's coming back and his lights are coming back on in his eyes, and it's been gone for so long. And he's had some traumatic brain injury and he's had some strokes. So for him, I think that the obesity was secondary to the strokes and to the traumatic that happens when you get, massive hemorrhaging or massive trauma to the brain. It will induce metabolic dysfunction pretty quickly in an individual. So I think for him, this might be a forever thing. And so keeping the dose as low as we can. And then my strategy, even with hormones, is to cycle. So I'll take them off for a period of time. I'll put them back on so that those receptors get naked again and they get revved back up. We don't want receptor resistance to this. And it's happening. I was talking to a compounding pharmacist yesterday and he's like, I've got patients that are at the highest dose and they're wanting a higher dose because it's quit working for them. So we don't want that to happen. And there might be other individuals who, maybe a young woman, say a woman who's in her 30s and she's had a few children and she's got that extra weight. Maybe once she loses that and she's really dialed in her lifestyle and her metabolic health, she may be able to just go off of it forever. Some of those people actually, I do believe there is the disease of obesity. I mean, there are genetic factors involved here. There's epigenetic factors. And I don't pretend to understand it all. I don't think anyone really can. Oprah Winfrey said it so well. She said, there are people who are obese who do not have the disease of obesity, and there are people who have the disease of obesity. And I think for some of those people, they might be on this lifelong, but there's an elegant way to do it. And then there's just a really disastrous way to do it. So I think that the nuance, like you discussed, and what I'm saying here, this comprehensive treatment strategy, which I talk about inside a course that I offer, is the ticket to making sure that if someone is going to stay on it, that they have success with it long term and they can stay on the lowest dose possible or lowest dose necessary. I, for one, will probably cycle this forever because it's been so impactful on my autoimmune conditions. And those are not going away. I can lifestyle them away, but they tend to flare up pretty quickly when there's extreme stress. Maybe I get a severe viral infection, something happens and you get knocked off gear and now your autoimmune disease is in full fire and you need something to put that fire out. And it's not just go carnivore. I mean, I wish that worked, but there's so many people that I have heard from that were like, I did everything so-and-so guru said, and I did everything so-and-so extreme guru said, and I'm still in this mess. And I'm like, I hear you, sister. Let's join the club. It's not as simple as picking a tribe, dietary tribe, and then, going full bore there. I mean, I know people that went carnivore that gained significant amount of weight and threw themselves into autoimmune disease. So, we got to treat the person in front of us.
It's nuanced. Once again, a couple of really quick questions before we finish. And I do want to talk about your Ozempic Uncovered, where you've got so much more information for people who want to get a little more information to dive deep into this stuff so they can hopefully get them self-treated. So first question, I was listening to an interview with Dr. Jason Fung. I'm sure you've heard of him. He's a big fasting doc. And one of the things he said was when he was treating his patients with Ozempic for weight loss for type 2 diabetes is that they lost the enjoyment of eating food and that they could only tolerate that for so long. And that's why a lot of people would end up going off of it. When you're microdosing semaglutide, do you also find that you lose that enjoyment for food, which is one of the great enjoyments in life? I mean, it's like, what are the great enjoyments of life? Like obviously food, sex.
What? Bro, what are you talking about, man?
Yeah. A glass of wine once in a while,
a good movie.
Yes, I did. I did that to myself. And so to me, that has been a dosage issue. So I have a long history of being anorexic, and I mean, severe. It was severe. And what got me out of it was strength training. Like I actually joke that I cured my anorexia with strength training. So I know that feeling of going so far, like I know it well. And when I was starting to get glimmers of that on the semaglutide, because I guinea pigged myself first before I ever started talking about this, I was like, no. I don't want to not want food, right? I don't want to ever go back to that. And my mom was really scared for me. She's like, Tina, do not go back into that. And I was like, don't worry, I'm not going to, because I'm being very cognizant of it, because I can't be strong and be, not eating. So that has been really interesting. And it is when I think the dose is too high. And I do know people who use it low dose and they will report that with patients, but they're doing like a cut phase on a patient. They're trying to get like 20 pounds off a patient. And this is a metabolically optimized patient, but they're going for like 20 pounds in 6 weeks kind of cut. spot. That's too drastic. That's not what I'm talking about. I'm not even, like I said, I'm rarely using it for weight loss. At these small doses, you should have an appetite intact, but you should have control over it. That's what I'm finding. There's a sweet spot. There's a really sweet spot where enjoyment for food isn't gone, but you're not having your sugar cravings and you're not wanting to drink. Maybe you have a desire to drink 4 glasses of wine a night. Maybe you just want one a few days a week or none. We're not trying to take everything away. I've seen it to be a dosage issue.
Interesting. And then as far as compounded versus brand name, any difference between them? Any recommendations for somebody? Do doctors make more money if they use a compounded version of it? What are your thoughts there?
I don't think so. So the compounded cost is very affordable especially for semaglutide. And so the way that I'm dosing people, it's costing them anywhere between $30 to $50 a month at most for their semaglutide. Really? Yeah. Because we're using standard compounded semaglutide. We're just dosing it very low. With the tirzepatide, that's a more expensive product, but I'll pull that out when I'm looking for more of that metabolic impact, or I want a little more oomph with the metabolic health, because it does have a better impact on visceral fat and treating and dealing with the liver, fatty liver, et cetera. So the studies haven't been done on tirzepatide and cardiovascular health just yet, like they have been with semaglutide. So we have different substances being studied for different issues if people are really sticklers about that. But that can be a little more expensive. It's 3 to 4 times the cost compounded, but still quite affordable compared to the brand name version. But if someone can get insurance coverage with the brand name version, something I've learned with some folks is that they can tolerate the starting dose. And in fact, the starting dose barely touches what we're trying to get at because their metabolic health is so disrupted when they're going into it. And so some folks have had great success starting with the prescription version. And, they have to qualify in those cases for coverage. They have to have a BMI of 27 or above and one comorbidity like cardiovascular disease, something like that, high blood pressure, or they have to have a BMI, I believe, over 30. And it can be a real hassle to get insurance coverage. But if they do, then insurance will cover it for up to 6 months. So some people are reporting back to me. Some people in my program are telling me, I could not get anybody in my town to compound it, and my doctor wasn't willing to do it. And so I started with a pen at the starting dose, and it's been just fine. And I'm getting a ton of benefits. And this is with the help of a good doctor because they will know what they're doing. They can help you keep the dose as low as possible while still getting the impacts you're trying to achieve.
Well, this has been so helpful. It's been so informative. And I think so many people's lives are going to be changed by just learning what they have learned in this podcast today. You've got a great course. It's free, I think, isn't it? All about Ozempic?
I have a free course and then I have a paid program that's a really deep dive. It's for clinicians and the general public, but the free one is very informative. It's called Ozempic Uncovered. It's a 4-part video series. I'm actually adding a 5th part, and it is all of the things we've talked about in deeper detail. So a lot of people are getting benefit from that and just educating themselves, and doctors are listening to it, and it's been a hit. So I encourage people, it's on my website, or you can go to drtyna.com. It's TYNA/Ozempic Uncovered. That's free. And then I've got hours and hours of podcast episodes on my podcast about it. So I've covered studies in there. There's just a lot of education there for free.
So if you're interested in what Ozempic, semaglutide, all of these GLP-1 agonists can do for you, whether you're looking at it for weight loss or whether you're looking at it just for overall improving your metabolic health, your brain fog, your cardiovascular health, this is a place to go. Dr. Tyna has become really one of the nation's go-to experts in this topic. And I think what I really love about what you're doing here is you are taking such a nuanced, in detail approach. It's not the kind of bang somebody over the head.
Crazy dog.
Get 20 patients in a day, injecting. It's taking each individual patient as an individual, unique person and looking at what their needs are, where they are kind of on their health journey, and then trying to personalize their care and their treatments toward each individual person. And it sounds like really what I've learned over the last week, really deep diving into this whole subject, your information and others, is that a lot of about these GLP-1 agonists is not really necessary, and that there is so much more to these peptides than I think people realize. And where you want to go to learn about this is Dr. Tyna. She's got the drtyna.com/Ozempic Uncovered. We're going to put a link in the caption of this podcast. And she's got a fantastic podcast herself, The Dr. Tyna Show. Thank you so much for joining me. This was a lot of fun, really interesting. And I think people are going to really get a lot out of this.
Thank you so much. This is so fun. And thank you for all your great questions. It was great to be able to explain it.
Well, thank you so much. And everybody, if you've been enjoying this podcast, if you could leave a rating or review on iTunes, Spotify, or wherever you get your podcast, podcast. It definitely helps me spread the word. And as always, I'm Dr. Anthony Youn, known as America's Holistic Plastic Surgeon. This is the Dr. Youn Show. As always, remember to eat real food, use clean skincare, and auto-juvenate before you operate. And we will see you next week, everybody.